everyone. I'm Verena Borwinkle, and I am excited to tell you today about the common data elements for disorders of consciousness recommendations from the working group in the pediatric population, which was recently published and is the first disorder of consciousness CDE tailored to the pediatric population. And this work was put together by my esteemed co-authors who did a fantastic job. And each of these experts in pediatric disorders of consciousness were assigned to the various working groups of this effort. And so that included the behavioral phenotyping, biospecimens, electrophysiology, family and goals of care, neuroimaging, outcomes and endpoints, physiology, big data, and therapies. So a PEDS member was embedded in each of these working groups, and their mission was to listen very carefully to the other members and steer the design of the individual working groups towards incorporating pediatric-specific CDE, including neonatal CDE, and making sure that the outcome of each of these working groups included the concerns that would also best forward the pediatric and neonatal patients who are experiencing disorder of consciousness and their long-term outcomes. So this was no small challenge for each of these experts. And monthly, these members met separately together so that we would crosstalk amongst each other to make sure that we understood what the other working groups' goals were, and tips amongst each other of how best to incorporate this age group into the output of these CDE. So during this process, we galvanized together what we found were the barriers to developing these CDE and what we could do to overcome them. And so a primary challenge was the lack, or rather the variability in the definitions of coma and disorders of consciousness in this age group, and a real dearth of outcomes for this age group. And so this definitely hamstrung our ability to say, well, we should use these definitions or these tests and so on and so forth, because there just was so little out there. And so because of this, the pediatric DOC CDE was not trivial to put together. And then confounding on top of all of this was the fact that 70% of the pediatric population who do survive hospitalization die from withdrawal of life-sustaining therapies, even after surviving hospitalization. But those that do survive, most of them improve significantly. So think about that. If we had the opportunity to have a subgroup of this population who were allowed to survive for a long period of time, we would know much better how to guide therapy. However, at the time and currently, this is not ethical. And so we see this divergence of outcomes, and the best we could do is to guide the current CDE to take this into account. On top of this, we know that children, and the younger the child is, the more likely they are to experience neuroplasticity after acquired brain injury. However, neuroplasticity is not well understood. There's very few studies with modern techniques evaluating neuroplasticity, especially in the very young. And so while we know this phenomenon exists, it isn't quantified. We don't well understand it, especially in this age group. And so advising our partners on these committees, it was important that we were there to do what we could, but at the same time, we needed to make sure that the vocabulary within these CDs incorporated what we did know, and so that moving forward, we could make progress. Okay, so I'm going to give a little laundry list of things that I'm going to point out that were different between, say, what one might think of for adult CDE and disorders of consciousness and pediatric. And this starts with even just a core element, the birth date. So oftentimes the birth date is very close, or is the birthday, the date of the injury is oftentimes synonymous with the birth date of the individual. And so for studies, when we collect the date of the injury, the option to have the age at the injury can be more protective of the identity of the individual. So we take this into account, especially for the pediatric age group. When we think about the level of consciousness at the time of the injury, we don't have great language for children because we don't have great standardized scale that helps us at the time of the injury prognosticate out far. And so currently we have incorporated suppression for age. So disorder of consciousness suppressed for age is actually adequate at this time in the CDE. Behavioral scales that have been validated in the pediatric space were incorporated, and these include the CRS-R PEDS, the GCS PEDS, and the 4 PEDS. So these are part of the CDE currently. So command-based paradigms, these are tests that take into account also the developmental level of the child. So oftentimes we query our patients with commands to understand if they're conscious. And now the CDE also take into account the developmental level of the child to be able to respond to these command-based paradigms. In terms of the hospital course, therapies that incorporated pediatric elements included the fontanelle puncture and head circumference. And these were included across all CRFs. And then in terms of outcomes, the pediatric specific outcome measures that were include the GOOS PEDS or the GOSE PEDS and the PEDS QL. And lastly, in terms of therapies, pharmacological dosage was scarcely explored in pediatrics for most therapies related to DOC, and device interventions were only anecdotally reported out in the literature. So there was very little specific therapy-related CDE that's specific to PEDS. And that's just a reflection of the state of the science. So I'm going to just briefly discuss the 6 CDE classifications, and these include the first and foremost, the general core. And these are required for all studies, regardless of the neurologic disease. And then secondly, under that is the disease core. So these are required for all DOC studies, regardless of the neurologic disease. And basic, which is also known as supplemental and highly recommended, was strongly recommended for all DOC studies. So in general, as a PEDS DOC researcher, we would take into account most likely the general core, the disease core, and the basic in nearly all studies related to DOC. And once we get further away from these highly recommended or required categorizations, the other CDE to think about are the supplemental, which is recommended for specific DOCs depending on the context or the goals of the study. And then we get down to exploratory. So these can be considered for use in DOC studies, but require further validation. And between me and you, many of the pediatric related concerns are in the exploratory category. Key design elements. These are not CDEs, but methodological parameters. And in terms of the pediatric concerns, many key design elements were reviewed with the pediatric lens in mind. For example, in resting state functional MRI, should we have sedation recorded and how much sedation they were on so that we can take that into account when we do connectivity studies. So we included neonates into this CDE because the neonatal age group is the largest uniform population of humans with the largest uniform causation of acquired brain injury, period. Furthermore, cooling of neonates with hypoxic ischemic encephalopathy is the most powerful therapy yet to date of all mankind in the reversal of the severity of injury and disorders of consciousness. So we have much to learn from this population, and I think not incorporating it from the get-go across the lifespan could be a huge missed opportunity for us, and also for the neonates. So some highlights I'd like to point out as a result of this effort that I have not yet mentioned, and one is the emerging role of genetic testing in DOC. The genetic testing has the potential to uncover novel host influencing injury susceptibility, epigenetic mechanisms, and recovery potential, especially in pediatric coma populations. And then lastly, I want to mention the resting state EEG and resting state fMRI have, because most children, when they have an acquired brain injury, often regress, even temporarily. And so relying on them to participate in command-based paradigms likely has a higher false negative rate than even the adult population. So the emphasis of these resting state paradigms will likely play an even more important role in these populations and could be eventually linked to covert consciousness and cognitive motor dissociation, which helps us understand their recovery potential. So with that, I would like to lastly just point out that all of these CDE can be acquired freely through Zenodo, and the link is provided on your screen. Thank you for your attention.